thank you very much for having me. It's my humble privilege and pleasure to be here tonight. And I'm going to talk kind of off the cuff. I have notes that I'm going to go off of, and I'll talk a little bit about what myasthenia is and about new sort of developments in treatment and studies that are going on right now and alternative therapies. And then I'll open it up to any questions. I mean, I think that's probably the most fun part, is the interactive part. You're not really an attorney, though.
I'm not an attorney, and I don't play one on TV.
One of our officers used to be an attorney. So she would always give me a big legal disclaimer. I'll just say the same thing Alexis did, which is that well, what I tell you tonight does not constitute medical advice for any of you individually. Happy to talk through, do you think I should discuss this with my doctor or et cetera, with you, within reason. And I'm used to getting curbside consults at parties, from people with headaches and memory trouble and all that. So I don't know. It's in my comfort zone by now, I think. So I guess I'll start with what is myasthenia. Most of you probably know it is a spectrum of different autoimmune diseases in which the immune system attacks the neuromuscular junction, which is the junction between motor nerves and muscles. And I say it's a spectrum because there are numerous different antibodies that have now been discovered that cause sort of the same syndrome. Some of them are a little bit variable, but similar. And as many of you probably know, there is also a wide and I think underestimated percentage of patients who have seronegative myasthenia, which is also an autoimmune disease. It behaves by it often behaves by the same rules. And in seronegative MG, it involves an antibody that just as of yet has not been discovered. So the antibodies that cause MG are the majority of cases who are seropositive, which is the vast majority of myasthenics, something like 80%, involve the acetylcholine receptor antibody. And so it's the most common type of myasthenia. It's sort of garden variety myasthenia is acetylcholine receptor antibody disease. There are actually, even within that category, there are 3 and maybe more antibodies that act against the acetylcholine receptor. There's a binding, a blocking, a modulating, and research has suggested that there are probably antibodies that act on other parts of the receptor. So that's acetylcholine disease. There's also Musk Myasthenia. Many of you have probably heard of that. The Musk receptor is also on the muscle, like the acetylcholine receptor, blocking it. So this autoimmune attack of the receptor prevents the nerve from being able to talk to your muscle efficiently. I mean, that's really what myasthenia gravis is. It's an autoimmune disease that prevents the nerve from talking to the muscle efficiently. So Musk disease is more common among women, especially younger women. It's often a more severe flavor of the disease. It often can go into crisis. It goes into crisis a little more frequently, and it is more bulbar, which means it more frequently involves the muscles of speaking, swallowing, and breathing. There are a few new antibodies that have been discovered even within the past 5 to 10 years. And one of the most important ones that's now now commercially available to test is the LRP4 antibody, which is the lipoprotein-related peptide number 4. Not to be confused with the other one. I don't even know what the other ones are, but this one causes myasthenia. And it also attacks the neuromuscular junction. LRP4 actually attacks the Musk receptor, just in a different place. So it also often is a more severe form of the disease. There's also an antibody called agrin. Agrin is an antibody that's often found in combination with others. There's not a whole lot of literature about the agrin antibody alone. And so it's kind of an open area of research what it means. It can be found in combination of people with Musk disease and a lot less frequently, actually, acetylcholine receptor antibody myasthenia. That's kind of an overview of the antibodies for myasthenia, for autoimmune myasthenia gravis. There's a myasthenic syndrome that many of you have probably heard of too, called Lambert-Eaton myasthenic syndrome, or LEMS. And it also behaves much like myasthenia. It's mediated by something called a voltage-gated calcium channel antibody. And Lambert-Eaton syndrome can also be seronegative. It can look just like myasthenia. And I guess I can tell you from experience, I have had several patients over the year who walk like a duck, quack like a duck. I don't mean that in a disparaging way, but it looked like myasthenia. Walks, quacks. What else do ducks do? Swim? They don't fly. Do ducks fly? I thought it was myasthenia, and it responded to conventional treatments. And for various reasons, so Lambert-Eaton can also can cause symptoms that are a little unusual in myasthenia, and specifically it can cause autonomic problems, blood pressure ups and downs, heart rate racing, and stuff like that. And so either because the patient had those, or because the patient was not responding like I thought they should to other treatments, I've gone down the road of sort of diagnosing that. It's a tricky one to diagnose when they're not positive for the antibody. And I can get into that at some point if you'd like to. But Lambert-Eaton is out there, so I guess just sort of for your knowledge, it is out there. There also there is a very rare category of congenital myasthenic syndromes, and that's myasthenia gravis that you are born with. It's very rare. It presents itself in childhood. It's very difficult to treat, and it is not an autoimmune form of the disease. The congenital forms of myasthenia involve genetic defects in the receptors that I've just talked about, either the acetylcholine receptor, the Musk receptor, something called the rapsin receptor. Those are present in childhood and often in infancy. Actually, I had a new patient today with a congenital myasthenic syndrome. He stopped breathing when he was 6 months old, and then went through he survived. And anyway, long story short, he's here, and they can't survive. He's in his late 30s now. Tough to treat, though. Very tough to treat. So that's what myasthenia is, kind of in a nutshell. The treatments for myasthenia gravis are expanding, which is exciting. And even just in the past couple years, many of you know, I think the first most important topic in the new treatment category is a drug called Soliris, or eculizumab. It was approved, I think, 2 Januaries ago, no, maybe 2 years ago now. It's been in the works for a while. I was actually, as a fellow 11 years ago, when I was doing my training with myasthenia, I was part of the safety trial, and I examined patients for my mentor, and when they were determining it was safe, the efficacy or effectiveness trial came later, and it's a very effective drug. It's worth discussing with your doctor if you have seropositive disease. So you have to have the acetylcholine receptor positive disease. It's the only way that insurance company, bastards, will pay for it. Don't get me started. Unfortunately, it's an unwinnable battle if you don't have seropositive acetylcholine receptor disease. If you do, it is a very effective treatment. It inhibits, and it's unique in the landscape of myasthenia treatments, many of which inhibit the function of B cells or T cells, which are circulating immune cells. Soliris inhibits the function of something called complement. And complement is a compliment is like when I see you and I say, "You look nice today." That's a compliment. That's a bad joke. So complement is actually a protein in the immune cascade that's downstream. It's what kind of happens after the B cells and the T cells have done their jobs. It's a very, again, unique mechanism of drug. It has been around for a long time. It's been around actually for decades to treat another rare autoimmune disease called paroxysmal nocturnal hemoglobinuria, PNH, autoimmune attack of the bladder that makes you pee blood at night. It's a very effective treatment for that, and because of that, there's tons of safety data. So it's it's not a brand new drug without a lot of experience behind it. Which is very important, I think. I mean, when we talk about any drug for anything, it looks very safe. The main risk that it carries that the other ones don't is the risk of meningitis, because the meningitis bacteria, Neisseria meningitis, one of the most common bacteria, enters your brain through sort of a complement-mediated mechanism. And so you got to get vaccinated for it. If you're vaccinated, Soliris is generally pretty safe. The incidence of meningitis is very low. So Soliris is exciting. Soliris is worth talking to your neurologist about if you don't feel like you're under good control and you have the acetylcholine receptor positive. Rituximab, I think I was standing right here like 2 or 3 years ago talking about how excited I was about rituximab. Rituximab, or Rituxan, is another therapy. I'll put it in the category of what's kind of new or what's great. In reality, it's been around also for a long time, used for other stuff. Myasthenia experts at academic centers have been using it to treat myasthenia gravis for over a decade now for refractory cases that don't respond to other stuff. It is an infusion drug, like Soliris. It's an infusion drug. It's categorized with chemotherapies, although for cancer, it's rare to use rituximab alone for chemotherapy. It's not one that makes your hair fall out. It's not one that generally makes you actually feel sick. So it is generally a very well tolerated drug. And it works by inhibiting a specific type of B cell. It's another type of immune cell. I have great success with rituximab. It is an off-label use, so it's important to have the conversation that it's not an FDA-approved treatment. However, there are now numerous case series, which is where myasthenia experts have put together studies involving 15 to 20 people, small groups of refractory myasthenic patients, didn't respond to other treatments. And numerous case series like that now show that it is effective and well tolerated, where other stuff fails. There's an ongoing study to determine, it's called a phase 3 study, to determine whether it should be approved by the FDA for this purpose. What I can tell you is that regardless of whether or not it is another treatment that is very effective and worth discussing with your doc if you don't feel that you're well controlled. I now have over 30 patients on Rituxan, myasthenic patients on Rituxan, seropositive and seronegative patients. And across the board, my personal experience is that it is generally a very effective drug, works where other stuff fails. And so it's another one that, I put it in the kind of the what's new category, but maybe the better category for it is what you might not know. It's been around for a while, though. What else can I tell you? Oral treatments for myasthenia, many of you probably know, the platform oral drug for myasthenia is or the two, they're very similar sort of cousin drugs, are azathioprine or Imuran or Cellcept, which is mycophenolate. They have very similar effectiveness. They're both pills you take every day, twice a day. They both work on T cells. They've been around for a very long time. There is one big, very well done study that shows that azathioprine is effective in myasthenia. It's the biggest study on any of the pills. In fact, I guess just in general, I would tell you, there is more data for azathioprine as a treatment for myasthenia than any of the other pills. Myasthenia gravis is a rare disease. I should have probably put that earlier. But for that reason, it doesn't get a lot of NIH funding. And it's also, for that reason, it's tough from a practical standpoint to put together any kind of big trial. So a big trial in myasthenia, is 30 patients. A very big trial in myasthenia is 100 patients, 150 patients. So azathioprine had, I don't remember how many patients in sort of the landmark study that was done, and it was done in the late 90s or early 2000s. And I want to say there was between like 50 and 75 patients or something like that, where azathioprine very clearly impacted the disease, improved weakness, improved daily function, lessened the incidence of crisis, and all the things that you look at in a myasthenia trial. Cellcept has been around longer, mycophenolate, and they're cousin drugs. And kind of whether to take one over another is a debate that MG experts often have. My main mentor, the myasthenia expert who trained me, his name was Michael Benatar. He was very academic. He is brilliant, and he practices a very data-driven medicine. Can't say how much I admire him. A lot smarter than I am. He chose azathioprine because it has the strongest data, and I follow his practice, and so I probably have more patients on that than any of the other oral therapies. You may hear debate. I mean, I don't know. I wouldn't want you sitting in a room where people are debating about that, because it's probably pretty boring. But honestly, there's debate among experts in myasthenia of whether Cellcept is actually better, and that's phenomenological. It's patients who have gray hair, wear bow ties, and have just used it a ton. And I respect that population too. There's just not quite as much data. A couple other oral drugs you may or may not know about. Methotrexate is another oral therapy for myasthenia. It's not that effective, but it's a much different mechanism than the other pills. And so it's something that we sometimes try where other stuff fails. I think you could count on one hand the number of patients I have on methotrexate where it is working and they're doing well. But there again, myasthenia, it's a spectrum, and every patient is a little bit different, and methotrexate is there. There's also a oral therapy called Cytoxan or cyclophosphamide. I think I'm down to one patient on Cytoxan. It is a toxic drug, like its name suggests. Cytoxan literally means cytotoxic. It kills cells or is toxic to them. It's an old-fashioned chemotherapy, and it makes patients feel pretty sick. And when you put it all on the scale, it's usually, if it's effective, it's not worth, in my experience, the side effects you get from it. But Cytoxan, there's another pill that's out there. Another very important treatment for myasthenia is IVIG. And I'm not saying this just because Todd's somewhere in the audience. I love that guy, by the way. I should say this from the very start, by the way. I do not take any money from industry. I'm not on speaker panels. They always ask me to be. I say no because I feel ethically conflicted talking about stuff if I'm getting paid for it. Much to my wife's dismay. I did take $300 from the Lambert Eaton people to talk about whether or not I liked drug companies. And and I gave them my honest answer, and they sent me $300, but I'm not on a speaker panel, so nobody's paying me to say this.
We're only paying you with Oreo.
I'll take Oreos. I'll take Oreos. So IVIG is a great treatment for myasthenia. I use IVIG in both myasthenics who are having an acute flare, an exacerbation, worsening symptoms, or I also use it off-label and off-label just means the FDA doesn't bless it. Not that that means anything, but I use it off-label as a maintenance therapy. So I have patients who get monthly or every other month infusions, you know, and how much and how often often gets kind of as much into the art as the science. It depends on how well you tolerate it. But I find IVIG to be tremendously effective, and I like it because it is not immunosuppressive. It does have some side effects sometimes, but it doesn't step on your immune system. It sort of gives it a boost, actually. And its mechanism is complex, but the main take-home, you know, is what I tell patients is it is sort of an immune booster, you know. So I like it for that reason too. And many of my patients who are sick in some other way, and I don't want to immunosuppress them, and that's not an uncommon situation to be in, or who can't wait for the conventional therapies to take place. And I guess I should go back to, you know, the oral drugs, the azathioprine and the methotrexate, the Cellcept, take a long time to kick in. So once you start azathioprine or Imuran specifically, there's a ticking clock that can go out to 12 months sometimes before you decide whether or not it's working. And that's a long waiting game. And so, I mean, in those patients, I always use IVIG as a bridge. And in many patients on other therapies, I find that IVIG is an excellent complementary treatment. In my experience with other local neurologists who I interact with, many of them aren't aware of that. And so it might be worthwhile to discuss with your doctor if you feel that you have symptoms that limit your life. And IVIG has not been something that's been put on the table. It's very effective, generally very well tolerated. It's not without a little bit of sort of side effects. I mean, no drug, no treatments without a tiny bit of risk. But overall, IVIG is an excellent treatment, I would say.
Excuse me, what are the side effects?
Sure. Sure. So the most common side effect of IVIG is a headache. And you get a headache because when you get it, your blood-brain barrier, which is where the blood vessels cross into the brain and transport stuff into the brain, they take up IVIG through something called active transport. So when it's circulating in your blood, the blood vessels in your brain start very actively kind of identifying it and letting it pass into it. And the headache is caused by irritation of those vessels and of the meninges, which is the covering around your brain. That's why the headache can feel like meningitis. The meninges cover your brain. When they become inflamed, they make your neck and your head hurt like crazy. It can cause sensitivity to light and sound. It can feel like just a monster migraine. Patients with headaches are more likely to get headaches. A lot of the time in those cases, I'll just proactively go very slow, give a lot of fluids, slow down the infusion rate. And I guess what I would say about the headache is that it is almost always either something you can mitigate or something you can prevent. With few exceptions, the headache is something you can kind of get around, just depending on how you dose it, how slow you give it, and how you pre-medicate patients. Benadryl, Tylenol, and a teeny tiny bit of prednisone or solumedrol, a lot of the time will cut the headache out either completely or it'll turn a 10 to a 2. The serious side effects of IVIG, it clears through your kidneys. So in rare cases, it can cause a little bit of kidney damage. It's actually rare for it to cause, you know, damage or of any permanent kind to the kidneys. It's not uncommon, though, to see the kidney numbers bump a little bit afterwards. The creatinine's the number that we use there. And if a patient's creatinine is 1, which is normal, if you check it right after a few days of IVIG, not unusual for it to go to a 1.2, 1.3, something like that, and then come right back down within a day or two. But that's something I put for that reason, patients with existing kidney problems, it's a little bit of a longer conversation. And so we sometimes try to avoid it in those patients. It's not an absolute reason not to. Very rarely, it can cause blood clots, too. So for people who are prone to blood clots, I will sometimes give them an aspirin a day if they're not already on it during the infusion, make sure they move their legs, make sure they walk a little bit, and give tons of IV fluids, which also helps to prevent that, that reaction, which is also, it's pretty rare. It's also not uncommon. There's a mishmash of, I would say, much less frequent side effects that can happen with IVIG. joint pain, fever, muscle aches, and rarely there is sort of an allergic reaction syndrome that can happen. Anaphylaxis, which is a full-blown allergic reaction, is very rare. But it's, I have patients every once in a while who will get, who will sort of spike a fever, feel like crud for a few days, and we sometimes chalk it up to just a low-grade reaction to the drug.
Like the flu shot.
Sort of like the flu shot, yeah. The shingle shot. Careful with that one. Shingrix. Who've done the flu shot?
No, but IVIG.
IVIG? Yeah. Oh, yeah.
Active doers.
Did you get a headache?
I have had, yes.
All right. Yeah, I saw you shaking your head when I said that. You don't? Mm-hmm. Hopefully you won't.
Sub-Q, no. Sub-Q is great.
I get a lot of questions, but I get two common questions. One is, can I do sub-Q? You may know there is now a subcutaneous form of IVIG you can give yourself. It is not approved for myasthenia, but I have found that I can get it approved if you're getting the IV form. The 2 or 3 patients I've used it in, I haven't had as much success with it in terms of its effectiveness. That's not always true. That's just my experience. It may not always be true. And it kind of hurt. The patients I gave it to thought it was painful. I don't know if that's been your experience. I don't know how much you want to share. Yeah, but my patients have found it to be painful. I did actually, it's only right now approved for immunoglobulin deficiency and CIDP, but I have had the patients who wanted to try it, and I think I've got maybe 3, maybe 4 now, I've had success getting it approved. I haven't denied it yet. Another question I get often on IVIG is, what about the brand? And the brands, what I can tell you is the different brands have not been studied in head-to-head trials, or they haven't been compared kind of scientifically. My experience, the brands I usually use, because they're either on formulary with my infusion center or with my infusion company that I prefer, are GammaGuard and Gamunex C. Probably got the most experience with those. There was a shortage recently of GammaGuard. And so, I don't know if that was just my infusion. Was that nationwide?
Yes.
Yeah, okay. And there's a weird reason behind that Todd can, why that happened, and Todd could tell you if you wanted. But anyway, it was kind of a little, like a mini experiment, because a lot of my patients who were on maintenance therapy had to switch from GammaGuard to Privigen. I mean, I can tell you there weren't too many hiccups. I did probably have 2, maybe 3 patients who didn't feel like it was quite as effective. Yeah, my go-to with IVIG is what's on formulary, what insurance will cover, and we can kind of fight the fight if there's a reaction. And I will switch if someone has a really bad reaction and there's not sort of a way that I think is worthwhile to troubleshoot it, with pre-meds or something like that. I've had cases where I'll switch brands, and it does seem to be tolerated reasonably well. IVIG is a protein. It also the protein can be denatured. It can kind of become bad in transport if there's some fluke. So if there's one bad reaction, if it's not that bad, a lot of the time I'll kind of say, let's see if you got, or especially if it doesn't work, I'll say, try it again. It often takes 2 or 3 infusions once you get started to feel the full benefit. And so I love IVIG. And again, they don't pay me to say that. I might change my mind, though. Let's talk after the meeting.
Okay, quick. We do have a question from Facebook World. It is from Mo, and she's asking, why is MG classified as a syndrome? No, I'm sorry. Let me just read it. Can someone ask, why is MG a disease and not classified as a syndrome like neuropathy?
That's a good question. It's both. I mean, MG, by all definitions of the word, is a disease. It's pathological nerve and muscle function that we know sort of the underlying mechanism for. So I guess by any definition, it's a disease. It's also a syndrome. So when I say a syndrome, MG is a spectrum so a variety of different clinical symptoms. I mean, that can include anything, and this may have been sort of appropriate for the beginning, but it can affect anything from your vision to your swallowing and speech and breathing to your limb power. And I'm sure you guys are familiar with the symptoms. The most common symptoms of MG in all takers are ocular, so droopy eyelids, double vision, affect, depending on the literature you believe, between 80 and 85% of patients, and can be very disabling, actually. Even though you can still walk with double vision, you can't drive or really function in most jobs. It makes things very difficult. The bulbar symptoms in MG, and this is, I guess, kind of, I'm going off on a little bit of a tangent, but bulbar symptoms, when we use that term, it refers to symptoms that come from the brain stem, which looks like a rose bulb. That's why they say bulbar symptoms. And it includes, most commonly, slurred speech, trouble swallowing, a little less commonly breathing. Breathing's actually involved in a number of patients subjectively if you talk to them. And it can be the most limiting when it's the salient feature of the disease. Another bulbar symptom, part of the bulbar syndrome, part of the constellation of symptoms that come from that part of the body, is facial weakness. And facial weakness is something the patients aren't quite aware they have. They'll say their smile looks flat because it affects the facial nerve, which goes paralyzed in Bell's palsy. And so it'll kind of just affect their cheeks, their nasalis muscle, and their ability to go like that. And so when they smile, they kind of looks flat. When that doesn't bother patients nearly as much as swallowing or breathing when it's there. So a lot of the time, patients aren't even kind of aware of it. It's the reason you can't drink through a straw, though. You can't make that seal. That's facial weakness. And then limb weakness is another very common symptom of MG. It takes all different forms. Across the board, it usually involves the legs a little bit more than the arms, although leg muscles are the biggest muscles. You know, they're what we make our way around the world with. That's where we go up and down stairs with. They are the biggest muscles in the body, and so they often, in active patients especially, the most apparent when they're affected. For some reason, myasthenia also affects tricep strength more than deltoid or bicep. You can see my huge muscles. I don't know if they're blinding you or not, but the triceps. You want to hear a funny story? Actually, my daughter saw Arnold Schwarzenegger in he's in this new movie where he talks about the plant-based diet. She saw a preview for it, and she was like, "Daddy, look at that man's arms." And she said, "Why don't your arms look like his?" And I was like, "Zoe, come on. I'm trying here." Picked up my weights. But, that's right. But the triceps are preferentially affected more than other arm muscles in a lot of patients. My mentor, Michael Benatar, wanted me to study that in fellowship, and I just didn't have time. But it's a phenomenon that is sort of described in some literature. It's the first thing I always test, your triceps, your ability to kind of push away, push out. And they are often much worse, much more affected than other kind of proximal arm muscles. So anyway, there is a spectrum of clinical symptoms that constitute the syndrome, which is the entire kind of basket. For any individual patient, it can be very different. So I would say myasthenia is both a disease and a syndrome. It's both of those things. So there's a long answer to a short question.
How common is it for MG to affect someone asymmetrically, just one side?
It's a good question.
I'm going to ask you, repeat the question so people in Facebook world can...
Sure. Oh, thank you. It's vodka?
Yes.
Good, all right. The question was, how common is it for MG to affect a patient asymmetrically, so to preferentially or to only affect one side?
Yes.
It's rare for it to only affect one side. It is common for there to be a little bit of asymmetry. By its nature, it often fluctuates. So I do have patients that will notice, even in a limb that they, sometimes if it's, they're right-handed and they use the right side more, they feel like the left is weaker. It's not uncommon to hear that. It's, I would say, uncommon for it to only be on one side. Not impossible. It would cause me to ask a lot of questions if it was. But I do have some patients in whom it's worse on one side. Not only on one side, but worse on one side. It's kind of cold. Did that answer your question? That's
Yes, and I have one more.
yeah. Oh, one, and hold that thought. Very common, though, for it to affect the eyes asymmetrically. Very common for one lid to droop more than the other one. Very common for the, and I guess I was referring to the body. And I have a number of patients, and this is well described, where it's only the right lid that droops, or goes out. So that is very common. What's your next question?
My next question was back to medications. I heard all of a lot of drugs that sound wonderful, and I'm glad I didn't even know that a lot of these drugs existed for the treatment of MG, because the only drug that I've known is Methotrexate. And does it actually do anything besides cause diarrhea?
Yes, it does. It does. It usually does. You beat me to my Methotrexate's next on the list. So pyridostigmine, that maybe should be first. I'm kind of going upside down here. But it's definitely not what's new. Methotrexate's one of the oldest treatments that there is for myasthenia. Pyridostigmine's its generic name. What Methotrexate does, it's another, I would say, safe drug. Side effects can be very annoying, and there's rare cases where they can be serious, but it's a safe drug. What Methotrexate does, you can imagine in myasthenia, a nerve is trying to talk to a muscle. The muscle's got 100 receptors, and 20 of them are blocked, and the nerve spits out acetylcholine 20 at a time. 10 hit the blocked receptor, 10 of them bind. What Methotrexate does is it boosts the amount of acetylcholine, the amount of the transmitter that the nerve uses to talk to the muscle, and it doubles or quadruples it. So instead of 100 acetylcholine at a time, there's 250. And so there's a lot more margin of error. It can, there's a bunch more acetylcholine that can kind of be wasted, that can bounce off the occupied receptors, but still there's room for enough to bind so that it talks to the muscle. And that gets complex, and there's a picture I can draw if I had a board about it that makes it simple. But basically, it improves your nerve's ability to communicate with the muscle. It also does that in autonomic nerves. Autonomic nerves are the nerves and this is why it causes diarrhea and some other symptoms, some other side effects. Your autonomic nervous system is your fight or flight nervous system. So that's called the sympathetic nervous system, and that's when you get a big rush of adrenaline, something frightens you, it kickstarts your heartbeat, boosts your blood pressure, constricts blood flow to your gut because you can't be digesting. You need that energy to run away from big woolly mammoth, if you believe in, the evolution. And because of that, and Methotrexate actually inactivates that nervous system and activates the parasympathetic, which is your rest and digest. So your parasympathetic nervous system gets a boost from Methotrexate, and that turns on secretions, digestive secretions, so which is saliva. It also makes you tear up a little bit, makes your nose run, and it stimulates gut motility. So that's a reason it causes diarrhea. Is Methotrexate blocks your fight or flight and boosts your rest and digest nervous system. The secretions bother some patients. Now, the diarrhea is the most common side effect, I guess. And a lot of the time, it's the limiting side effect. You titrate it until there's diarrhea and then back it up a little bit. And hope for a sweet spot in the middle where, it's effective without the diarrhea being too bad. By the way, there's a remedy for the diarrhea, too. So if Methotrexate works really well, and you don't want to try something else, you don't want to try the other immunosuppressive drugs, there's a drug called hyoscyamine, or Levsin, which blocks the diarrhea side effect. Now, it's a drug to treat the side effect of another drug, so it's not ideal. But in cases where Methotrexate is effective, but you run into a wall with the diarrhea, or the other side effects, makes your stomach gurgle sometimes, which can be a cosmetic or twitches, or it can cause cramps, it can cause muscle cramping too. It's not uncommon. Levsin blocks those. It'll make your eyes and your mouth dry, but it will block the side effects and still allow Mestinon to, often still allow Mestinon to kind of have its effect on your strength and your symptoms of MG. Just today, actually, I got a message back from a patient. We had started Levsin last week. She said, I want more Mestinon because it was working. It was bad, and it said she's another case where Mestinon is all that I'm using. You probably count on 2 hands the number of patients where Mestinon alone is what I use to treat the disease, but they're out there. They're out there.
All right.
Yeah, that sometimes happens.
A couple questions from Facebook world. This one's from Jesse Bird. What is your opinion regarding the use of steroids for the treatment of MG? What can combat fatigue? That one's from Jackie. That's it for now.
Steroids is the next topic. I was going to, so prednisone is another one of the oldest treatments for MG. Prednisone is, as you probably know, is a corticosteroid. I hate it. It's a devil drug. My goal when somebody starts prednisone is to get them off prednisone. Because long term, it works. It will often, in fact, the majority of patients improve with prednisone. And it's not a bad choice if at onset your symptoms sort of quickly become severe, start limiting your life. In those cases, and if Mestinon doesn't work, I'll add prednisone to those patients. I tell them the day I give them a prescription, we have to come up with a plan to get you off this. It's a devil drug. It works well, but long term it can cause the side effects. I'm sure you guys are all too familiar with me. In the long term, it'll cause weight gain. It'll spike your blood pressure. It'll melt your bones, cause osteoporosis. It can cause or worsen diabetes. I mean, all that said, I do have patients where we end up on a maintenance dose of prednisone. In those cases, the goal is as low as you can go. Yes, sir.
I just had pneumonia recently, and when I went to the doctor, they not only prescribed an antibiotic, but also prednisone. I'd gotten off of prednisone a long time ago because of the 74 side effects, right?
Mm-hmm.
Well, not that, however many. By the time I got to the pharmacist said she wasn't giving me prednisone. I said, why? She says, because you're on Mestinon.
No.
I said, really? Because I know that in this forum we've talked about that a lot, and I know that many people here are on both.
That came up once for a home health pharmacy for me too, and I don't know the rationale behind it. They absolutely can be used together, and I do often. Let me look it up on Hippocrates while I take the next question. Because I looked this up, and when she called, I had a home health pharmacist that was adamant that we couldn't use them together. And I said, I've got about 60 patients I got to call, so I'm going to cancel my clinic. And I looked it up, and
I wasn't going to argue with the pharmacist because she's got a lot more education than I do.
and I want to be respectful. Anytime, I certainly don't know everything. Don't tell my wife this, but I certainly don't know everything. She actually does. She does. Even if she's wrong, I do it. I just don't ask any questions. I'm going to see what Hippocrates says about this. I'm just curious now. But you absolutely can take them together.
Can I ask a question? Have you ever tried Plaquenil?
Combination, hold that thought. Combo may decrease cholinesterase inhibitor muscle stimulating effectiveness and cause weakness and myasthenia. I don't. That's just simply not true. That's according to Hippocrates. It is a low risk / monitor / low likelihood. That's a no-no. I'm sure why they did that for you is their computer program flagged it. But
I didn't want it anyway, so I'm glad she didn't give it.
Right, I don't like giving it anyway, but if you need to, you can't. You and then you. What was your?
My question was, have you ever, because I'm on it for mixed connective tissue, but have Have you ever used Plaquenil in MG as an immunomodulator?
I have a couple patients who have combo autoimmune syndromes. It hadn't worked in any of the ones that I've tried, where they kind of came on at the same time. Plaquenil's a good, yeah, I mean, Plaquenil's a safe starter drug for unconnective CTD, or even sometimes in lupus. But the patients who I followed out, their myasthenia wasn't budging. Yeah, so I would say no.
Repeat the question, please.
What's considered a maintenance dose of prednisone? The absolute lowest possible dose that you can get down to, you know, without worsening disease. I mean, and I would tell you, and I'm not trying to be smug, I mean, I try, once patients are down to 10 milligrams a day, I usually decrease it extremely slowly, because depending on how long you're on it, it can put your adrenal glands to sleep. And so if you come off it, if you've been on it a long time and come off it too quickly, you'll feel sick for a few days. Your adrenal glands, which make cortisol, sort of sputter to start again, and it'll make your blood pressure go low and just make you kind of feel sick. And so for that reason, and to try to hit a sort of a safe low dose, I'll go, if I'm at 10, I'll go to 9 milligrams a day for a month, and then 8 milligrams a day for a month. And then if they feel anything getting worse, I'll just hold the dose, just try to have the patient push through it, wait for whatever else we're doing to work, and just check back in. I have patients on 10 to 12 and a half, sometimes 15, but if you're on any more than that, I'm getting you off of it. And really, if you're on any, I'm getting you off of it. And before this question, starting off on high doses of prednisone, or if you're not on prednisone, if you have an established disease, you're flaring, high doses of prednisone, which I would define as 40 milligrams a day or up, and certainly above 60, can make myasthenia acutely worse. It's a well-known kind of phenomenon, and so it's not an uncommon problem to run into in a hospital that either doesn't have a neurologist, or where the neurologist doesn't maybe know MG well, for them to give you pulse dose of steroids or high dose of steroids, and the patient's getting weaker and weaker. So that's just something to keep on your radar. What's the next question?
The next question is from Cindy. Is Rituxan used if Solaris does not work?
That's a good question. It depends on the patient. I have, not always, I would consider both of those to be the king of immunotherapy, the king and queen, and I don't know which is which, but of immunotherapy is Rituxan and Solaris. I have more patients on Rituximab now. You know, I guess over 10 years, and many of you probably know the oncologist I know. I'm sure he wouldn't mind, he's spoken here before, Ethan Tolbert, prince of a guy. And he and I have gotten Rituxan approved for over 30 patients now, so I have more experience with it. The majority of them have bumped up several levels of function. I mean, it's been good or great. It's been a game changer for the majority of the patients I have on Rituxan. I now have, I think, either 11 or 12. I think I've got 12 now on Solaris. It also seems great. I've tried to push it through for a number of seronegative patients or one Musk patient, and I ended up cursing myself red in the face with an insurance company on the phone, and for now, I'm not going to do that again, because they put up a big wall, because it's such an expensive, unfortunately, for drug. But either one, did that answer the question? Okay.
Okay. I got one more question so far that I missed. This one's from Jackie, and I think I know the answer to this one. Does Methotrexate cause weight gain? I was going to say the Oreo cookies did, but I'll let you answer the correct one.
Shouldn't. It's not one of the side effects on the label. I don't know if any of you have had. I have not experienced that, and I've used it a lot. I know it's not on label. You and then you. How you doing? Good.
Okay, you were talking about the diarrhea, and I have a question about it. So, the drug that you recommended, I can't pronounce it.
Icosapine.
Okay.
Hyoscyamine,
Yes.
or Levsin.
Compare that to ammonia.
So the question is, how does hyoscyamine?
One versus the other.
or Levsin, sure, compared to Imodium. It is, I find it's often more effective for diarrhea when it is a side effect of Methotrexate. Imodium works. I worry about Imodium for the same reason as we don't like patients taking it with any kind of a chronic form of diarrhea, because it can cause colon problems long term. I have patients who still do it, and I'm always like, get off that. You need to get off that. But I would recommend, if Imodium works, the patients I have who take Imodium, I try to space it out. I try to say, I mean, either in those cases, I'm trying to convince them to take Levsin, or for some reason, if Levsin makes them feel too dry, because it turns off the faucets, so to speak, that Methotrexate turns on. You know, the faucets are your runny nose, runny eyes, oral secretions. Diarrhea is the unpleasant faucet. But it'll sometimes take it a little too far. It'll cause sort of bothersome dry mouth, especially. So I do have patients where I kind of navigate that with Imodium, and usually I like them to take it like 2 or 3 times a week, and to try to avoid it and take holidays, because it backs you up more. Did that answer your question? Give you to talk to your doctor about Levsin. That's an adorable puppy.
So has the test become available for the new antibodies that, as they're discovering now, if we're seronegative and on immune suppressants, would those tests show up or not show up because of the immune suppressants?
That's a good question. I get this one a lot.
Can you repeat it, please?
There's a 2-part question. The first is, are the new antibody tests commercially available? And the second was, does treatment, immunotherapy, change the detection of those antibodies, change whether or not you find them in the blood? The answer to number 2 is, we don't really know. That it's not something that's been well studied. Along those lines, though, there's a lot of data in acetylcholine receptor myasthenia that the titer or concentration of antibody does not seem to correlate with the severity of the disease. And so there are patients who have an extremely high concentration of the acetylcholine receptor antibody. You know, normal is, I think now they've sort of said it, normal is like either 0.3, less than 0.3 or 0.25. And there are patients with a titer concentration of 300 in the blood, several orders of magnitude higher, who have a droopy eye once in a while. And there's patients with a titer of 1 who are, you know, who have terrible, severe disease. And so that has been studied. But whether immunotherapy affects, I mean, it should theoretically affect antibody production. It's just not a studied thing. For seronegative patients where it limits their life, it's not, I guess waiting for antibodies to show up isn't sort of something you should do. But the bottom line, I guess, for that question is it's just something that's been well studied. I mean, theoretically, it might lower your levels. To this first question, there are now commercial tests for LRP4 through the Mayo Clinic, and I think maybe Athena now. And there are commercial tests for Agrin through also, I know Athena does, and I think Mayo does now too. Musk is commercially available through most labs. Titin, which is another antibody that affects patients with thymomatous myasthenia, myasthenia associated with a thymoma, and that's commercially available. What to do with it is still kind of a question, because if you got a thymoma, it needs to be resected. And there's another one that Mayo Clinic does that can cause, and the voltage-gated calcium channel antibody, which causes Lambert-Eaton syndrome, is commercially available through most all labs. And what else was I going to say? I think that's it.
You got a question?
Yes.
This next question is coming from Neely. It says, any suggestion on timing of getting the flu shot before or after a treatment? And I'm going to add a little caveat, regardless of what his answer is. If you choose to get your flu shot, you can do like I did today. I went to Publix, and I got it done for free, and I got a $10 gift card. So I don't work for Publix, but I just happened to be there picking some pumpkin pie for you all, and I saw the free flu shot, and they give you a $10 gift card, so that offset the cost of the pumpkin pie. So there you go. Take it away.
So my answer to should I get it, treatment should not affect whether or not you have a reaction to a flu shot significantly. Sometimes patients who are immunosuppressed, if they have a reaction, it seems to last an extra day or two. I mean, the CDC and I think the MGFA too, I believe, I can go back and check this, but I know they've got a vaccine statement, do recommend, and I do recommend getting the seasonal flu shot.
MGFA does.
I thought so, still. It's not a live vaccine, and so if you're immunosuppressed, it is still kosher based on sort of the criteria the CDC uses. And along those lines, I'm respectful. I tell patients to get it, and if a patient says, no way, doc, forget it, I say, are you sure? And then if they still say no, I mean, my approach there, because getting the flu is bad news if you're immunosuppressed. I have one patient 3 years ago who died, who was immunosuppressed, myasthenic, who was kind of also fragile, but who died of the flu. I mean, that may or may not have happened anyway. I was a very fragile person. But my opinion is that you should get it. If you don't, and even in some patients who still are fragile, a lot of the time I'll give them a prescription for Theraflu to have on hand. If anyone else in the house gets sick, or at the first sign that they have symptoms, pharmacies if you get that at the early end of flu season, like now, the pharmacy will fill it. If it's in the middle of flu season, their stock often runs low, so they won't do it unless you say you got the flu. But for my patients who I'm worried about or who don't get who refuse a vaccine, I insist on them keeping Theraflu on hand. Tamiflu, I'm sorry, Tamiflu. Yes, not Theraflu. Theraflu, I think that's the T. Yeah, Tamiflu. Thank you. Yes, sir.
You mentioned live virus. I needed a yellow fever shot, and when I talked to my neurologist, he said, no, you're not getting one. I go, why? It's a live virus. I went, okay. So why can't we have live virus?
Here's how to answer that question. Live viruses, you're more likely, if you're immunosuppressed, to have a reaction to the live virus, to get sick from it. That being said, I have a patient who travels internationally, and she goes into corners of the world where these things live, and she actually works for the CDC. Interestingly, she's a doctor too. She has to get live virus. She cannot travel or do her job without getting the live viral vaccines, and she's got, to my knowledge, and I think she's gotten the ones she needs to get, and she didn't get sick from them. But the reason that you don't always, but there's a much higher likelihood that it'll make you sick if you're immunosuppressed. And so, yeah, I would, yeah. So you got to just put everything on the scale and weigh it out. We still very cautiously and with a large disclaimer can do it if it's absolutely necessary for something like travel or something like that. Answer your question? Yes, sir. Oh. Yes, sir.
Theoretically, if there was a person that was diagnosed with ocular MG about 6 months ago, and the medication that they're taking is the Cellcept and what is that?
Methanol.
Okay. And it hasn't helped with the double vision.
And theoretically, if he's holding the bag of medicines up while he's in this very hypothetical patient.
Careful of the insurance.
Sure.
Or attorneys.
Yeah.
Sure.
But anyway, is it too early to start considering surgery? Should they try something different? Should they try longer? More
Surgery for what? Thymectomy?
Yes.
Thymectomy is a good next topic. So the question is, in his friend,
Yes.
who
You're asking for a friend.
is ocular myasthenia, who he knows very well, with ocular-only myasthenia, only ocular disease, is that right?
They don't know for sure yet. That's what he was diagnosed with.
Sure. So there's a couple of important points, I guess, from that question. The question was, is it too early to consider a thymectomy if you were diagnosed 6 months ago and drugs aren't working, Celseptin, pyridostigmine? The answer is it is not too early to discuss thymectomy. Thymectomy is an important, my first issue with that is shorter. Many cases of generalized myasthenia where it ends up affecting the whole body start as ocular, more than half of them. And so, I mean, my message, not to frighten anybody, my message in patients who have isolated ocular symptoms, and it's the first sign of the disease, is that we wait and we watch very carefully, and I educate them on things to look for. I mean, you know, including the fatigable limb weakness, shortness of breath, trouble swallowing, et cetera, et cetera. It's not uncommon to become hypervigilant to yourself and to like feel that you have something, maybe you don't, it was a hiccup here and there. Then it's still a wait. By all the studies that have been done, if generalized disease is going to declare itself, it usually does it within 2 years, usually. Majority of patients, and I think the number that when there was a big retrospective trial and basically looked back on a bunch of patients and interviewed them, but the 90+% of patients who are going to spread within 2 years. It's not always true. I do have patients who have been outliers to that rule personally myself. So I guess that's where I would start with that. As to is it too early to consider a thymectomy? No, I don't think so. Thymectomy, it's an important next topic, is another non-pharmacologic long-term treatment for myasthenia. I feel strongly that young, relatively young, otherwise healthy women, and young can mean up to like 40 and even up to 50, so young, who are healthy without a major contraindication to surgery should seriously consider it. And in my patients who present, especially my women, and that's because data is strongest in women, although there is data that thymectomy helps men too, and I do it for men too, so I don't discriminate. But you know, the women who are under the age of 30 with generalized disease should absolutely have a thymectomy unless there's a compelling reason not to. I mean, if they don't want surgery, that's okay. It's a very safe surgery now. Most of the experts who do it robotically. They can get all of the tissue that with a well-studied robotic procedure. It doesn't leave a scar on your chest. I've had great results with it. It takes several years to decide whether it worked, and you don't know the alternative universe. So I can tell you, many of my patients who have gotten thymectomy do seem to have less aggressive disease. It's my unscientific kind of observational opinion. And the big study that showed that that was true came out in JAMA, I think 2015 or so. Enrolled patients with acetylcholine receptor positive disease that doesn't, any myasthenic can still get a thymectomy, but they enrolled seropositive patients, and their benefit, the curves of patients that got it and patients that didn't, split right around 2 years. And as you follow them out further, I think there's like 5-year data, maybe more. I think last year, maybe they published 5-year data. But the further that study follows these patients out, the more clear it is that the patients who got thymectomy have less aggressive disease. I have patients who have wound up disappointed who say, I thought I wasn't going to be on drugs, and I never said that. But many of them are functioning or are only on Methotrexate or have, you know, mild disease that doesn't disable them severely. I mean, I guess so, you know, coming back to this hypothetical man, it is something that should be on the table for discussion, but it very much kind of depends on the surgical risk, other medical conditions, et cetera. What I would tell you is if you interview a cardiothoracic surgeon for thymectomy, find one that only does thymectomy. Find one that only does mediastinal and chest procedures. There's nobody that only does thymectomy. But find one that's done a lot of them, who's done a lot of myasthenics. There are several in Atlanta. I'll toss them out. I love Seth Force at Emory. Seth Force, F-O-R-C-E at Emory. Jeff Miller is also a very good one. Smart guy. He's done a lot of myasthenics. And Shady El Daif, I haven't used him as much, but I've talked to him a lot. I've shared a couple pages with him now. He's new on my scene, although he's experienced, and he seems good too.
He was one of our guest speakers here once, and he was fantastic. He showed us some videos on some of the surgeries that he had performed.
Yeah.
And he was very, very familiar with myasthenia gravis.
Yeah. I love it. Jeff Miller and Seth Force have become personal friends. They're both, I mean, I can't say good enough things about them as people and as surgeons.
What was his name again?
Jeff Miller and Seth Force, F-O-R-C-E. Like, may the force be with you, sort of. Yeah. Same spelling.
What are the odds after you have the procedure that would get rid of the double vision?
No, it doesn't do it right away. Doesn't do it right. What I would tell this man is that it's going to be years. It's going to be years before we say, did it work or did it didn't?
So this may be premature because you just started talking about thymectomy, but you had said that it was several years to determine if it worked. So that was with somebody without a thymoma, with a thymoma, or it doesn't matter?
Good question. What I'm talking about is non-thymomatous disease. So patients without a thymoma, just where you take out the thymus.
So if you add in thymoma?
Thymomas must come out. Thymomas must come out. They're generally benign tumors, although they will rarely spread, but generally they're benign tumors that they can grow and invade the outside capsule, and they can cause problems, all kinds of problems, if you don't take them out. And so I guess by any cancer guideline, they still should be removed. And in myasthenia, there's no question about that.
So is the years to determine if it works the same as without a thymoma?
It's a good question. There's not data to that. They haven't done, there's not any type of controlled trial that evaluated patients with thymomas that weren't removed. Anecdotally, it does seem to alleviate the disease a little bit. It does seem to kind of lessen weakness a little bit. And it's an interesting question, too. A higher percentage of patients with thymoma have multiple antibodies that are positive. I mean, basically it's just thymic tissue that's revved up and, to over-generating these antibodies that occur. So it's not uncommon. In patients who have multiple antibodies positive who don't have a thymoma, I say you've got a thymoma. We just got to do, it's got to come out. I mean, either way, a lot of the time those have got to come out. I can tell you I have patients in that situation where all 3 acetylcholine receptor antibodies were positive, where they got a thymectomy and they found a tiny little encapsulated thymoma. The scan just doesn't see it. And you guys probably know this, or you may know it, but in patients without a thymoma, something like 70 to 80% of patients with myasthenia, 70 to 80% of patients, when you take that gland out, it's abnormal under a microscope. So it shows something called thymic hyperplasia, which is a sign that it's overactive, that it's revved up. So it's another interesting fact.
She's got a question, and then I have one.
Yes, you.
Non-thymoma question.
Okay.
So, not that you know anything about me, but
no, of course.
So, as you know, I've had a lot of insurance issues. Things that previously were said to be going to be approved have been starting to be denied. They've really cracked down. So, first part of the question is the Rituxan. You said there's a phase 3 to get FDA approval. Is that for all myasthenia gravis, or is that for acetylcholine positive? Is that for a small group?
I have to look at that study again. No, it's a good question. Because Emory was a site, but I don't think they're enrolling anymore a few years ago. I can look into that. Portal me a reminder and I'll look into that.
Thank you. The other part is it seems like most of the medication now, obviously because I'm in a minority, being seronegative. The research and the new medications are geared towards, obviously, the majority of people. What do you see in the landscape for seronegative MG patients?
It's a good question. I'm an optimist at heart, but for that question specifically, what's in the landscape for seronegatives, I do think that the future is bright. I say that because there are several drug trials. One that I regretfully we got approved as a site, and I had my first patient lined up to enroll, and it was a unique drug. It was an argenx drug, and anyway, without getting too huffy about it, basically I had my first patient lined up, and we had everything ready to go. It was an Ig fragment, very unique drug that looks pretty effective in sort of small trials, and they enrolled seronegative patients so that you could have seronegative muscular acetylcholine receptor disease. That made me look out at several of the other drug trials in development, and several of them are enrolling seronegative patients. And so that actually, I mean, it gave me tremendous hope just to see that, because the reason a lot of big drug studies don't is because the data is just not as clean, sort of. And it's tougher to prove. It can be a gray zone of whether or not somebody has seronegative myasthenia. In my world, we make it black and white, but in the world of research, you can enter into a gray zone of like, how abnormal does your single fiber EMG have to be, or your repetitive nerve stimulation? Basically, how do you prove that you've got it? Becomes a grayer area in research. That's why researchers don't like it. Portal me about that, and I'll look that up. Yep.
All right. A couple Facebook world. I'm happy to announce that Neely will spend the $10 from her flu shot getting herself a sub sandwich. No, but on a more serious. I've got two questions, and they kind of fall to what you were just talking. This one's from Serena. Is Rituxan effective in treating Musk MG? And then I'll let you answer, and then I'll come to the second question.
Absolutely. It's the first-line treatment of choice for Musk MG. I'm glad that yes, I'm glad you asked that. It's a good question. I don't think it's actually also, it hasn't gotten FDA approval, so it's technically off-label, but it is the treatment of choice. If you ask any 10 MG experts who are much smarter than I am all over the country, all 10 will say Rituxan.
Thank you. All right, so that one was for Serena. This one's from Julie. Is there any research showing the benefits of any dietary changes, such as keto, autoimmune protocol diet, etc.?
I'm glad you asked that. That's on my list. Diet and exercise in MG. The answer to that question is sorta. I can tell you the more diet is studied in autoimmune conditions, the more apparent it is that it impacts them. Western medicine as an institution is kind of a dinosaur. To prove something, you often have to sort of jump through many unnecessary hoops. It often requires randomized and controlled trials where this group only eats this diet, this group only eats that diet. That has not been done for myasthenia. That being said, there's now a lot of research, a large and growing body of literature that shows that there is benefit for autoimmune conditions. There's benefit to the plant-based diet and something that's broadly called the anti-inflammatory diet. And there's several different definitions of the latter. A woman who, when MG patients ask me that question, I actually try to bring that up sometimes. It's often number 9 or 10 on the list, and we forget to get to it, but it's a very important point. The resources I give MG patients are, there's a woman who has MS who has published who's widely published. She actually is some kind of doctor, I don't know what kind, but she has MS, and she dove into this anti-inflammatory diet, and she defines that very specifically. She lays it out for exactly what she did, and it helped her a lot. She went from a wheelchair to walking. She got a lot of energy. and her name is Terry Wahl, W-A-H-L. So when patients say, well, where should I start if I'm interested, I direct them to, she's got a website, and she talks about her diet called the Wahls Protocol. It's pretty intense. I mean, it's a lot of vegetables. She uses a little bit of organ meat, which I don't like. So I tell patients, look, sip the Kool-Aid, but you don't have to drink it all. That's right. But she's a good starting point. She's got a lot of recipes, and there is no question there's something to it. And for MS, there actually is now, it's the one autoimmune neurological disease that there is a lot of data for now that's growing. The diet clearly impacts the progression of the disease. I mean, the mechanism is similar enough, so I think it's an important thing to bring to the table in myasthenia. I also give the patients, there's a book called, the title of the book is called How Not to Die. And catchy title, it's by a Western medical, allopathically trained doctor, so Western MD, who became kind of disenfranchised that we don't teach diet in Western medical. We teach macronutrients, like how much protein, how much carbohydrates, basics of what they do. But there is a lot of data behind diet and its impact on other diseases, especially cardiovascular disease. And so his preface is, it's a shame that we don't teach all of our doctors this. And then the rest of the book is, here's the data that there is. So he kind of lays out what we know and what we don't about diet's impact on things. And I mean, the plant-based diet is kind of what his revolves around. He talks about other stuff. And many of you know I'm kind of a diet weirdo. Some of you have known me for more than 10 years now. I used to be big. I started practicing what I preach, and I got a lot of energy. And I'm mostly plant-based with a little bit of fish, but I love it. I profess it. I preach. So, yeah.
No more questions so far. Oh, yeah. Two things. Catherine says, I love my MG warrior. That would be my wife. She's just saying hi to everybody. And Jessica asking, what is the name of the book?
How Not to Die.
How Not to Die.
I can't remember the guy's name. Easy title to remember, right? It's very catchy.
And one more thing. So it is 8:04. I want to be respectful of everybody's time and your time. Mm-hmm. I'm not saying we got to leave right now and stop it, but if you have to leave or something, we totally understand. We want to be respectful. I don't want to leave yet, and so we'll abuse Dr. Brown.
You got me. Nah, I like the abuse,
yeah.
Not abuse.
But it is 8 o'clock. I'm just doing a quick time check here. I know we have more questions, so if we can go for a few more minutes, that would be great.
So I've been doing immunoglobulin treatments for other things for 10 years, since 2009. 2.5 years ago, started having the weakness in my legs. It has progressively gotten worse, trouble swallowing, trouble with my arms. I've been through the gamut of tests, the Musk antibody normal, the alkaline receptor less than 30, everything points to normal except for everything that I'm going through. Mm-hmm. Is it possible that because I have been on such a long-term IVIG regimen, could that be throwing off some of the tests?
I guess what I'd tell you is it kind of goes to your question too. It's not something that is well studied. So that one's a maybe. What I would tell, if there's still question of the diagnosis and if myasthenia is on the table, the next step, if a patient is seronegative and if the symptoms are limiting your life, or even if really they're not, you need the diagnosis, the next step is electrophysiology, which is like the repetitive nerve stimulation, single fiber EMG.
Actually, I'm scheduled for the single fiber at Mayo next week.
Good. Hopefully that'll get you an answer.
I hope. I just didn't know if it could throw things.
It's a maybe. Okay. It's a maybe. Yes?
I have one quick question. It's back to Ivig. I've been told that after
Mm-hmm.
Okay, and that's what I didn't understand, because I had read that it might take anywhere from possibly a year to, you know, I just wondered what's the earliest that.
So there's a little bit of literature to this. There are, in the biggest study that was done, and in most studies that you see, before the published study a few years ago, there was a lot of surgical data, which is kind of messy. Surgeons do not make the best researchers, but the surgical data showed what kind of this big, fancy, sort of well-done study did too. So they basically they were very similar. But most patients, it takes a little while. 2 years, I think, was the median. Many patients will sort of start to feel a little bit better, within 6 months to a year. But I'm a cheerleader until you hit about the 2, and even some of the 2.5, 3 year mark. I do have a small handful of patients, and there are reports of this, that got better pretty quickly. Like within months of the thymectomy, they were clearly getting a lot of altitude, and it was, they were stronger and doing stuff and didn't need their drugs anymore. I do have a few patients like that. I watch them real closely because I kind of wanted, myasthenia can be a squirrely disease, and so in those cases, but I have some that they got a lot better and they sort of stayed at that plateau. So it can happen. Yes?
General question, so definitely have to answer. For immunosuppressed patients, is there any tricks, tips, advice you can give? Instead of keeping a virus for 3 to 5 days, keeping it for a month and a half. Mm-hmm. So is there anything to kind of counteract lovely immune system?
Airborne and vitamin C. I'm a big fan. And I mean, kind of common sense. It's tough. It depends on your exposure and what you do. Teachers, especially folks who teach kiddos, that's the worst. They're little incubators. They're coughing everything all over you. But also crowded workplaces. I mean, viruses float around. So I guess the best advice that I could give is have a low threshold to call in sick if you feel a little sick. I love airborne. I love vitamin C. Through flu season, a lot of my patients, I'll just say, especially patients who are kind of sickly or who have gotten something before, just take 1,000 milligrams of vitamin C every day. Get the chewables. Keep airborne on hand. I like airborne. It fizzles. It's effervescent. Is that what that is? Is that?
No, it's helpful. It just takes so long to recover.
Yeah, I mean the recovery. Don't go back to work until you feel, good.
A month and a half.
Oh shit! Sorry. Yes.
Rise for MG patients that are HIV/AIDS positive. How much damage does one do to the other?
That's a really good question. I have one patient I can think of who is in that category. He and his HIV is excellent and under excellent control. His viral load's undetectable. He's on one of the new triple therapies. I can't remember. I do not immunosuppress him. It makes me very nervous. He's on and off a low dose of prednisone, and he's on pyridostigmine. It's not an absolute contraindication. You still can use some of the immunotherapies. He's actually doing very well. He has never had particularly angry myasthenia. My short answer to that is, it's a tricky line, but you've got to keep the HIV under, good control. It's possible to sort of live for a normal life with HIV now, and so his myasthenia is actually his bigger problem. But fortunately, it's like we play whack-a-mole with prednisone. He flares a little bit in prednisone, puts it down, and we take him on and off of it. That's a tricky. My best advice there is make sure the immunologist is communicating with the neurologist, because IVIG is also a great treatment option there, actually.
Now the myelinating cell cell because of its involvement with T cells. Would it cause a false reading when they test?
They can still, it should, and they can still check like a viral load and stuff like that. And it's not, you can take those with HIV, actually, you can. My guy actually, he's gotten IVIG. I can't remember why. He had some kind of a reaction to it. But IVIG is also an ideal, potentially an ideal maintenance therapy in that standpoint, because in that situation, because it doesn't suppress you. Yes, you in the back.
Brown, thank you. I know everyone appreciates you coming out tonight, so we definitely want to compliment that. Considering you're one of the MG specialists in Atlanta, I know it can be challenging for a lot of patients to actually make an appointment with you because you are booked out for several months. What could you tell us about the rest of Laureate Med Group colleagues that also treat MG patients? Because that question comes up a lot.
Sure. I'm not actually that great. People just think I know what I'm talking about, but I use big words. You know, it's funny, I didn't come to market my practice. I didn't even bring cards. It occurred to me on the way here, I was like, I probably should have brought cards. I'd be terrible at marketing. My group, I love my group. My unbiased opinion, we're the best. There are several neuromuscular specialists within my group. So David Williams did the same training as I did. So did Radhika Sampat. Both of them are, I would say, at least as capable as I am. We share, so we meet as a, and all of our neurologists, Dr. Nuccio and Dr. Cabrera, Dr. Green, and Dr. Qureshi, they did different types of training, but they're all very smart. I've actually known all of them for years, several years at least, before working with them here. You know, I mean, my short answer to that is, so for patients, I rarely say, and I don't want to get the floodgates open, but I rarely say no to a new myasthenia patient. I just tell them, call Raquel, she's going to be, by the way, guys, I have to say, Raquel, my nurse who is fabulous and does all of the work is right there in the back. Raquel, say hi. Amazing. She is amazing. She makes, without her, the whole operation would fall apart. And so she is, I can't say good enough things. But what I can also tell you, all of us talk to each other about our difficult cases. We meet once a month to do a case review, and it's like scans that we see that are abnormal. Cases are difficult to treat. Every month there's a myasthenic on the table. We meet for a couple hours every month. Every month either I or one of my partners puts one on the table. And talks about it. So we are very much a collaboration, I have trouble saying no, though. Is that right? Yeah, she's saying yeah. I have trouble saying no. I'm a yes man. But all my partners are great.
Yeah. Earlier when you were talking about Methotrexate, you mentioned, you know, that it turns the faucet on, all this, you know, mucus and stuff. And when I was searching about myasthenia, I ran into an offhand reference in another article by an ER physician, and he was saying the very few times he's seen myasthenia patients die or almost die, it was because they were drowning in their own fluid. Was that a different diagnosis? Or?
That's called, when that happens with Methotrexate, rarely Methotrexate can cause what's called a cholinergic crisis. It's usually patients who are on high, it's rare that it happens on standard doses. It usually happens, you know, you take the 60 milligram tablets. I have seen cholinergic near crisis a few times, and I've had one patient who went into it. He was taking, I think, 12 a day of the 60 milligram Methotrexate of the instant release. I had gotten him up to 8 or 9, and he was taking a few on the side. And one day he was a police officer, traffic officer, and he was fortunate because he had a partner with him, and he was like, I'm wheezing, but it's wheezing and hypersecretions, drooling, but you usually see that train coming a long way away. I mean, unless you take a ton of Methotrexate all at once one day, and your dose changes, you can usually, the drooling, the secretions, and all that stuff, it'll happen in a dose-dependent fashion. So I've had a few patients who are sensitive to it, where at 4 or 5 a day, they felt like they were drooling because they had such secretions. I said we got to back it up. But I mean, it's something. I would say the ER should be seeing more just primary respiratory crisis when it's a crisis.
Well, are there other common conditions that we should look out for that we could confuse with either too much Myasthenia or too little Myasthenia, which usually has like the same kind of symptoms, if your dose is off?
Too much, you'll be real runny. Like the nose will be running, you'll be drooling with too much. Usually, and wheezing. I mean, it's the bronchial secretions that kind of shut your lungs down and make you wheeze. So it's secretions deeper into your lungs that do this. You'll be kind of coughing and wheezing. For Myasthenia toxicity, it kind of makes people feel like they're sick or they have a cold. They'll be coughing and kind of wheezing. Much more so than like with just myasthenic respiratory weakness. It's more trouble drawing a breath. Not everyone follows the textbook, but that's usually what I would tell. So it's pretty rare to get to see a cholinergic crisis.
Speaking of Myasthenia, do you have any information on like what is too long a time to take it, or have there been any studies on that at all?
You mean how many years?
Yeah.
That's been around for decades.
So it's okay for a patient to take it forever, or type thing?
If it's working, I would say yes to that. It's been around since the 70s, maybe even a little bit of 60s.
60 years old.
60 years old, even a lot longer then, a lot longer. It's been FDA approved for myasthenia, I think, since the 70s. It's one of the FDA approved treatments for myasthenia.
Was the first one.
It was.
And then Eculizumab Solaris was November of 2017.
It was number 2. Yeah, those are the only two
Those are
technically.
the only two medicines.
Technically, actually, yeah. So I'm very comfortable with its long-term use. It's working. Yes, you in the back.
I have a quick question about pain. Me and some others, when we overdo it, we have a pain like in our bones that kind of feels like growing pains. What would cause that?
It's a good question. I get the pain question in myasthenia often. In the textbooks, you read that it shouldn't cause pain. And the truth is, if you overdo it, if you overuse a muscle that's weak, then you'll strain it. The most common pain syndrome that I see in myasthenia is patients who have neck extensor weakness will get neck pain because these muscles, your cervical paraspinals, are very small and they are constantly holding up a bowling ball. It's your head. And you don't think about it. You're subconsciously pulling your head up. So patients with, in fact, it's the way, when patients get neck pain, localized neck pain with myasthenia, if I didn't know they had a head drop, I bring them in and I say, we got to look, that's from the myasthenia probably, and we got to explore it. The same thing happens with arms and legs, with limb pain. So my short answer to you is it does happen. It's pretty common, actually, if you directly ask somebody. It's not the first thing that they'll say. The first thing that a myasthenic patient is going to say is, I'm having trouble walking across the room, not like my hip hurts a little bit. But pain from just strain, mechanical strain, is a very common phenomenon. And in the case of, if it's something that's bothering you, I would keep an activity log and say, what are you doing? When's it, what provokes it? Why did it get worse? How many stairs did you climb? Who did you go boxing with? Or whatever you did, whatever activity it was, to sort of just drill down your boundaries of acceptable exercise. Yes?
Speaking of acceptable exercise, what is acceptable exercise for myself? I got on the treadmill. I was on there maybe for 5 minutes. I couldn't have been going, but just making 2 steps. And I almost slid off because my legs no longer was able to, to hold up. And then the gym kicked me out.
Jeez.
Nicely.
Really? What a bunch of jerks.
Well, because I was now a liability.
Right.
And I could not return unless I had a letter stating from my doctor that I was able to use the equipment and to exercise. So if exercise is good for the muscles, how to make the muscles good for the exercise? So
it's an important, it's actually on, it's next I think on my list. The old credo in myasthenia used to be that the muscle's fragile, the neuromuscular junction's fragile, don't overdo it, you know, and be sedentary and don't exercise. And that is categorically untrue. So there's been research that's come out within the past 10 years. Every study that's been done both on myasthenia and on myopathy, which is primary muscle disease, and on muscular dystrophy, which is a form of myopathy, all those categories of diseases, and myasthenia is one of them, have been studied. Exercise helps neuromuscular transmission. And it does so by something called pruning the neuromuscular junction. So the more you use a muscle, you know, the more the nerve kind of shoots at it to get a signal, the more the more it stimulates the muscle to grow better receptors or to slough off receptors that are either broken, bound, or not working. So there's basic science data and clinical data that show exercise is good for the disease. Now, what to do for exercise and what an individual patient should do is, I mean, that's very different from patient to patient. My short answer is you have to do something that's safe and, you know, and just kind of just use common sense when you get started. Start low, go slow, you know, do sort of short sessions. With my myasthenia patients, a lot of the time, if they're deconditioned also because of the disease, because it's a sticky wicket. I mean, it's something if you can't function and you've been on prednisone and you're couch bound from your disease, your muscles are also a little bit deconditioned from that. So there's several hurdles to get over. So I will often use either a physical therapist to design a safe exercise program, or I'll start with aquatic therapy. Unless the patient really doesn't like to swim, I love the water. If you crash, you splash, you don't hurt yourself. It's good aerobic and anaerobic exercise, depending on what you do. It's good for the muscles. And it's a long-term plan. I mean, you know, it's another thing where I'm sort of a cheerleader for my patients. You know, it's not going to happen tomorrow. You're going to phase it in. We're going to set long-term goals. But exercise is good for myasthenia and for your general health. And so it's, you know, it's something that it's another thing that I preach. All right. Anything else? Yes, you?
An ocular question. So this is in general, but tell me if it's not too general. So I was 3 years ago or whatever diagnosed by a neuro-ophthalmologist with ocular myasthenia, he thought, and then I kind of went on a different path and ended up, you know, CVID and mixed connective tissue, and ended up going back to him because I still get the droopy in the eyes that don't work. And he said, no, I still believe what I said the first time. And I tried the Myasthenia, woke up, you know. So ended up on Plaquenil, Ivig, still have the eye issues. Is there eye surgery, like, do you recommend any kind of eye surgery to just fix anything to help?
Most of the time it doesn't work.
Okay.
They'll droop again. If there's different kind of lid lifts they can do. And there's different a strabismus expert sometimes will try to realign your eyes, but I would not do it. I have now, generally we don't recommend it.
All right, I'll come figure out something
All right. I've had a number of patients actually who did it anyway, and none of them are happy.
Really?
And if you get a second corrected, the more you have, the deeper you go into the restriction. I mean, you know, they'll kind of restrict your abduction if your eye goes in, so they'll kind of yoke the eye in and it'll get tethered. And the deeper, then this one won't work, because myasthenia is variable around the eyes. I mean, it can look several different ways on different days. I have a patient who's actually, it's a sad case, but she's got sort of irreversible restriction of her movement because she kept on going,
My aunts have had a couple
even though I told her not to. Yep. Yes.
Is a thymectomy recommended for seronegative patients that are still having?
That's a good question. That's a good question. It should be discussed. Oh, I'm sorry. Is thymectomy recommended for seronegative patients? My answer is yes. It has not been studied in patients who are not acetylcholine receptor antibody positive, but I have done thymectomy in a number of seronegative patients, and it still does seem to work. So my short answer to that is yes. And most MG experts, there's a little bit of disagreement about this, but the majority of MG experts who have experience will say yes to that question.
What's the link you were saying earlier, 50, 30 to 50, but.
Yeah. I don't draw an arbitrary, I don't, there are patients in their early 50s who or late 40s who I've talked about.
And then how long
thymectomy.
if seronegatives have been under treatment for, several years?
Mm-hmm.
Is that too late already?
No.
Like a cutoff,
There's not an absolute cutoff. There's not an absolute cutoff.
What is the purpose of the thymus?
In an adult, it sort of technically shouldn't have a purpose. As a child, it's an important, and an infant especially, when you're as a newborn and an infant, it is an important part of the immune system. Once you turn 2 to 3 years old, it shrivels up and pops and disappears in a lot of patients. So many patients don't have residual thymus. Those who most myasthenics do, and I'm just kidding, it doesn't actually make a pop. But most myasthenics do have residual thymic tissue. It's rare for me to find no thymus on a CT. It's not uncommon in other patients to, you scan them and they don't have thymic tissue.
So there is no repercussion from the removal? It's just taking excess tissue out?
That's right.
Okay.
That's right. It's sort of an accessory immune gland. You don't actually need it, and it's yeah.
All right, folks. We're going to wrap up the questioning part, but let's give this man a big round of applause.